Welcome to Mastering and Guideline in Ultrasound and Echo. As you know, all internal organs like the intestine, liver, kidney, lung, all of them has been surrounded and covered by a fibroserous membrane that we call sac. In the intestine we called it peritoneum, and in pleura, around the lung we call pleura sac. Heart has been surrounded by a fibroserous membrane too, that we called it pericardial sac or pericardium. Before I go more detail on the pericardium structure and function, I have to mention some clinical point here. As you can see, and I mentioned, the heart is in mediastinum or mediastinum, and is surrounded by two lungs and posterior with the vessel and esophagus and vertebra, and front by chest wall. There are some other structure that close to the heart and relevant to heart, because in some clinical situation it affect. For example, here we have a phrenic nerve that passed through to the lateral wall of the superior vena cava here. And in ablation, is AFib ablation, sometimes it can damage the phrenic nerve and cause diaphragm paralysis. Or we have a recurrent laryngeal nerve that go past through under aortic arc here, go up. In some situation, especially physical force like the aortic dissection or aneurysm, or huge enlargement of the pulmonary artery or LA enlargement, can press that nerve and cause hoarseness of voice that we call Ortner syndrome. Or sometimes we have some tumor or enlargement of thymus that is anterior to the aortic roots and sometimes goes more beyond. Maybe you can see in the plaques view. Just keeping in your mind those other structure around the heart. Now let's go see the structure and function of the pericardium. Pericardium, by its attachment to the surrounding structure like the diaphragm, sternum, vertebra, and vessel, through the ligaments, it keep location of the heart stable and almost fixed. And knowing those structure and ligament, especially for cardiac surgeon and cardiologist interventionalist, is very important and critical. Pericardial sac consists of two sacs. One inner sac, we called it serous pericardium, and outer sac is fibrous pericardium. And heart has been embedded in inner sac and surrounded by outer sac too. And for understanding and imagining better, let's give this example. Imagine your fist is heart and the balloon is inner sac or serous pericardium. And the space inside of the balloon is pericardial cavity. When you want to embed your hand inside of the balloon, that this balloon is flexible and deformable, very easy. And without rupturing and penetration, tearing the balloon, you cover your fist covered by the balloon. Even the grow, all area covered by balloon. So in this case, and you can see here, still we have pericardial space there, and we have some dead end or returning of the wall here and between those finger and grow, so it create some kind of the recesses, sinuses, or cul-de-sac that shortly I am going to explain about those spaces. So generally speaking, heart surrounded contact directly with the inner sac, and the pericardial cavity formed by inner sac, and all of them surrounded by outer sac or fibrous pericardium. Let's go a little more detail. Here we have a schematic of the heart and pericardium. As you can see here, we have here two wall and three membrane or layers actually. Let's see how they are. The pericardial cavity is between the inside of the serous sac. Serous sac means has two layers. One layer that connected to the myocardium, we called it serous pericardium visceral layer. So visceral layer or epicardium that stick to the myocardium, heart muscle. The outer layer is parietal layer that contact to the outer wall or fibrous pericardium, and between them is pericardial cavity. Here we have a little more detail. As you can see here, we have outer wall, and here we have parietal layer of the serous pericardium and inner layer of the serous pericardium that we called it epicardium. So serous wall or membrane is squamous-like monolayer mesothelial cell, one layer of the cell. And the outer wall is fibrous and consists of the collagen fibers and elastic fiber. And the thickness that only include outer wall, the normal situation will be less than 2 millimeter. In constrictive pericarditis or other neoplasia of the pericardium, it increase thickness. The way the pericardium sac surround the heart and its vessels, it create many dead end and sinus, recess, cul-de-sac, all those stuff. And the clinical implication for this recess and sinus is that in many situations, especially in imaging study on the CT scan, MRI, and sometimes in the transthoracic echo and transesophageal echo, we will see those area, and it can confuse with pathology, especially on CT scan and MRI. Let's see some of those. The most important is sinus transverse and oblique sinus. Here these two, and the other around all those vessels you can see recess. Each of them take the name, anatomic name. For example, if it's posterior at this area, we call it posterior vena cava, posterior caval right, or inferior cava right, and so on. Here we have some of those that it can make confuse with some pathology, especially dissection or some kind of neoplasia on CT scan and MRI, and we should aware of that. Here you can see we have transverse sinus. Both of them are cross section, short axis. It looks like you're cutting the body short axis and watching from the below, from the foot. So posterior, anterior, left, your left become right of patient, left of patient. Now here, you can see each of them, they have the same name. For example, here we have ascending anterior superior aortic recess. Anterior superior aortic recess This one on the TE, on the transthoracic echo, you cannot see it, but posterior superior here, you can see it in the sometime in suprasternal notch long axis, posterior superior aortic recess. This one in one of those multiple choice question, it was this answer, and so on. For those people they want to study more, they understand those things, I strongly recommend for resident especially go get to these two lecture by Dr. Fadel and Nasrullah and other Dr. Lil and Marcus. They have a good lecture about this sinus and races and their clinical implication, especially in situation and differentiation of the pathology. Here we have some of those races, but here just only sinus I show. Here we have both TEE. You can see here sinus transverse. Here the same. You have to not be confused with the left atrial appendage or auricle. How you know? The appendage open to the atrium. Here doesn't. And this area is triangle limited to the pulmonary artery, left atrium, and aorta. And with heart movement, you can see a little shape, it's collapsed or become smaller or shape change. Here on the transthoracic, on the plaques, sometimes you can see at this level. Here, this is T on the three-chamber view, is the same spot, the same spot. Here is more clear, is triangle. This is transverse sinus, and above that is pulmonary artery, right pulmonary artery. So how you can differentiate is pulmonary artery or sinus transverse. With the heart activity, the sinus shape change, pulmonary artery shape doesn't change. And if you put color, you can see the Doppler color on that is completely different. Here we have oblique sinus. Sometimes you can see fluid goes to the posterior of the left atrium. But usually because of position and all those stuff and other structure occupy posterior of the left atrium, you don't see fluid very easy on the plaques. As I mentioned, pericardial cavity has been filled with the pericardial fluid. Generally speaking, the pericardial fluid is formed by ultrafiltrated of plasma between the capillary and the space and lymphatic vessel, and the changes of the osmotic pressure, colloid pressure, hydrostatic pressure, those differences create that mechanism of ultrafiltrate of plasma. The amount of the potassium on the pericardial fluid is a little higher than the plasma, and osmolarity is lower. The amount of the normal fluid in the pericardial cavity is usually 20 to maximum 50 milliliter, and during 24 hours it's turned over or renewed at least 3 times. The major white blood cell in pericardial fluid is lymphocytes, a little higher than the blood. There has been more than 10 function and role has been explained about the pericardium. But even with those roles and function, still there is not consensus about that we closed or leave it open pericardium after open heart surgery or any after pericardiectomy. Here, those that like to, they are interested to know more, there are Hearst book you can go study, or a review by these doctors. They did good job. Innervation of the pericardium is a little different. The visceral pericardium is supplied by autonomic sympathetic trunk, and the result of that is the pain will be non-specific, is like the other visceral pain, and usually accompanied with the nausea, sweating, and all those stuff, all arrhythmia or change into the cardiac rhythm because of the vagus nerve too. But the parietal wall supply by somatosensory branches through the phrenic nerve that is responsible for the referral pain in the shoulder, arm, neck, and all those stuff. Like the other any part of the body, the fat can be deposited and accumulate around the heart too, depending which part and which layer of the heart pericardium has been deposited by fat. We have divided in two. One of them is epipericardial, or sometimes they call parapericardial fat pad. That is beyond the parietal pericardium. It means out of the pericardium layer, the fat deposit and accumulate. Usually the location of this fat is at the apex and at diaphragmatic level of the heart, and it can be everywhere. The other one is epicardial fat pad. This type of fat deposit fat between the visceral epicardium and myocardium, and sometimes the fat deposit inside and infiltrate inside of the myocardium. The distribution of this type of epicardial fat pad is usually interventricular and atrioventricular glue. Here around the base of the heart, between the connection of the atrium and ventricle, atrioventricular glue, and interventricular, anterior and inferior interventricular glue. That epicardial fat pad supply blood by coronary artery, but the epipericardial fat pad supplied by mediastinal vessel, phrenic, and all those stuff. The gold standard for diagnosis of pericardial fat pad and measurement is MRI. In MRI, we can differentiate it, the mid-gray, and between them there is a dark line that is pericardium, so that this one will be parapericardial fat pad or epipericardial fat pad, and the inner one will be epicardial fat pad. Here the same at short axis, you can see dark line, this pericardium, and this one is para, and this one is epi. On the ultrasound echo, we can appreciate it with mid-gray, usually mid-gray echogenicity, but sometimes is hyper-echo depending on the angle of the insonation and orientation and location of the fat pad will be a little hyper-echo or more hypo-echo. Here you can differentiate, you can see epicardial fat pad very clear. This patient has cardiac tamponade, some degree collapsing of the right ventricle. Here we have C fluid, and this one you can see pericardium here and epicardial fat pad in here. When we have prominent epicardial fat pad, we have to measure it. Still, there are not some agreement what is the normal size, but generally most of those specialists agree if we measure at the diastole more than 5 millimeter, that is the cutoff for the too much thickness of the epicardial fat pad. We are done this part of pericardium. Have a wonderful time.